Thanks, Dr. Coleman. You can stay right there. And Dr. Trent, Ms. Barkley will join you, I hope. And I don't know if Dr. Wyatt was able to stay on in Zoom. Do we have a way to check that? We'll check and see if she was able to stay on. If not, we'll go ahead with the Q&A.
I'm here.
She's on. Oh, good. Dr. Wyatt's on as well. So the panel can address questions to any of the four speakers, and just let me know who wants to start first. Jessica at Willoughby.
Thank you. And thank you to all of our panelists today. Some of our presenters specifically mentioned different interventions, and some of them using digital technology for those interventions. My background's in mobile health, and one of the issues that we often see relates to scalability. So you find these interventions that work, and then how do we get them to a larger population? My question to you is, what are your concerns or thoughts or suggestions surrounding scalability of such interventions?
I think that if we build it and we teach them how to use it, we will be able to scale it up. I don't think I think those things are easy. I think that the human components that are going to be harder or more difficult for us. So for us, we do pair with the technology, the community health nursing. The data suggests that young people want to communicate with somebody on the other end that they can trust. They're very savvy about technology. And so I think that our ability to build relationships is the more expensive part. I think that technology actually is the easy part. But I think that we've got some exciting things that are emerging that allow us to communicate in real time, to allow us to measure adherence with patients without having to be real time, that are going to transform sexual health, I think, as we know it.
I think that the accessibility to services is, it's all going to go here. This is the future of primary care and even tertiary care. And so we have to figure out the mechanisms for developing these technologies and scaling them up.
I mean, I think once we figure it out, rural areas are going to probably seriously benefit. And I think telemedicine is probably going to need to play heavily in the solution. And it's coming because I'm hearing about it more and more used in very different ways. So I think that telemedicine is going to really be a key.
My other comment, though, is that I don't think that means that we need to dismantle the safety net for young people. What I've already seen is that this shift to try to move people into primary care settings means that there's less funding to public health clinics, to health departments, to adolescent clinics. There's one of me for every 100,000 adolescents in the United States. We have to make sure that they have places to actually go. Even as it relates to something like expedited partner therapy, I think that is wonderful when you really can't get the patient in. But what we find is when we're able to get that partner into clinic, it really changes his opportunity to have his risk assessed, to have his own visit. So I think it has to be a balance. As we move towards more technological engagement, we cannot leave behind the hard work of actually caring for patients and putting our hands on them.
So Medina Agenor and then Patty Kissinger.
Hi, everyone. Thank you so much for your testimonies today. I'm Medina Agenor. I'm a social epidemiologist, so I really appreciated your focus on history and also on the structural factors, so thank you for that. My question is, have you seen any interventions that have been successful or promising at addressing some of these historically determined structural factors, either multi-level interventions or just purely structural interventions around STIs that you could kind of point me towards? Thanks.
Gail might want to respond to that. Gail, are you hearing us? No.
Dr. Wyatt, can you hear?
I can hear, yes. I had mentioned my interventions. Some of them have not necessarily elicited structural changes. We have shown the county that they need to standardized hours, standardized fees, train professionals to give feedback to diverse populations, but none of those issues have been taken on yet.
I think that there are some studies that have looked at the impact of gay marriage, of other provision of sexual citizenship to people are extremely effective, and I think that those really should be surveyed.
Kissinger.
Again, I'd like to echo thank you so much for great presentations. This is a question for Dr. Coleman, I guess, mostly. So I work with young people a lot, millennials, Gen Zs, and they don't necessarily want love or intimacy. In the hookup community, they're really interested in just physical and pleasure. And so Tinder, Grindr, all these things, how do we get across putting intimacy back in without sounding like a fuddy-duddy baby boomer?
I'm not sure what studies that you have looked at, but I know that Debbie Herbenek has really studied this issue and has really found, despite the myths that that's all that they are interested in, is that love and commitment and relationships are just as important as previous generations. And so there's a lot of myth out there that that's all it is about, but when you do the study, those are things that are important to youth.
Would you be able to provide us with at least some of those
Certainly,
papers? That
certainly.
would be awesome. Thank you very much.
Yeah.
There's actually a group out of Ohio that has done a lot of work on adolescent relationships, and it actually really, I think people think it's gendered as well, that it really suggests that young men are actually quite vulnerable, that because young women actually have a lot of experience with intimacy in the terms of the way we socialize from very early ages, physical touch, being together with each other, that those things are really very common amongst women as they grow up, girls, but that boys have less of that and that they have to learn. But then we also have super high expectations of young men as it relates to them functioning in relationships, as it relates to sexual prowess. And so we're not really allowing them the opportunity to develop a healthy sexuality alongside that. The other observation that I see in inner city communities that we serve is that they don't have a lot of role modeling oftentimes on how to engage a partner in a positive, healthy relationship. And so while they may be engaged in sexual relationships, I think their ability to create intimacy is something that's very challenging for them. I know that our studies have found, again, that people, once they get in it, they're like, oh, this is great. They love being in it, but getting them in is very hard. They're also, I think they're fearful of it. So I think it's an area worth investment in helping young people develop those relationships.
When we have been developing our interventions and we are doing focus groups with the target population, including youth, and we ask them what they want, well, yes, they want to know how to use a condom, but probably the most important thing they want to know about is about relationships.
Right, thank you. Dr. Niraj Sood.
For anyone on the panel, I think a lot of people in this room, agree that the first report, Hidden Epidemic, was an excellent report. Yet, all of us agree that it had no impact or little impact in the sense we're still talking about the same issues 20 years later. And so I find that kind of, how can we like a report that didn't change anything? Are we just talking to ourselves? Are we, missing something? Because it's likely maybe this report might, when you look at the report, there are a lot of reasonable things that report said, yet a lot hasn't changed. So I feel like, do you agree with that assessment, or do you think we should be doing something differently here? And maybe another question is, are there, we're kind of talking about a strategy for a whole country. Are there other countries that have been successful in the last 20 years maybe not a country, a state, a city? Can we point to any place where we can say, look, they've done it, and so we can do it too?
Very good question. And I actually think the hidden epidemic had an impact. It really exposed the problem. But strategies have to be long-standing, and you have to have those long-term kind of goals. And so the UK, Australia, they have strategies, and they follow up with those. They have national surveys of sexual behavior regularly to monitor and, in terms of what's going on. You can't just issue one report and then forget about it. It really has to have a real sustained kind of approach, and a body like CDC or all of us to really follow this strategy over time. If this document just sits there, no, it's got to be taken up by the partnerships and follow through with that. But there has to be ongoing monitoring. As I understand, there's going to be a new IOM report on LGBT health. They didn't leave it at 2001. They're going back to that. Healthy People 2010, 2020. Look at those things. We have very few indicators related to sexual health in those, but if we do establish a strategy, and we haven't talked too much about indicators, we have to have indicators to really show that we're making progress and hold ourselves accountable to those.
All right. The last three questions will be Willie Prado and John Schneider and Vincent Irano Ramos.
So this is a follow-up to Jessica's question around scalability. And oftentimes with these behavioral interventions, and I'm a behavioral scientist by training, it takes almost 20 years from intervention development to scaling up, if we can actually do the scale up. And I'm wondering what your thoughts are in terms of trying to narrow that window down. There's been some literature written about innovative research design and other things that can be done. So I'm wondering, what are you all doing, if anything, around that area?
Let me just say, Ned Hook and I started talking to the CDC in, Ned, 2007, 2008, about the sexual health frame. And when we did, and then we had the first meeting that Eli referenced, everybody in the room was like, what? What are you talking about? How does this work? How does this impact me? This will never work. And it has snowballed since then. Think about how the subject of sexual health has changed. You see people who use it correctly, step one, because in the beginning we didn't. And so I think that we're in a different place and time. I think that part of that is technology and the amount of absolute information overload that everybody gets. And we're trying to control that. And I'm sure Pinterest, for instance, is trying to make sure that the the anti-vaxxers are controlled. So there's things that are happening that are helping us do what it is that we're trying to do. And so I like to think that we're on a much faster trajectory than we were when the Hidden Epidemic came out, because it was a book. It was a great book. But how did that get shared with the broader public? That was the huge dilemma.
I think we also have to be able to rapidly, so studies, particularly those that show results, receipt of funding, to then manualize it so that you can send it out. So after your paper's now published, it takes additional work to manualize that for other people to make it work for them. I think that's a process that we have to think more carefully about from a funding perspective. I think the other issues, for example, I'll just take our tech and intervention. If somebody wanted to scale that up today, if we wanted to scale that up just in Baltimore, we could do that. People who just come to Hopkins, we could do that. The question is their will to do that. The reality is Hopkins owns its own home health company. There's no reason that we can't train the cadre of nurses to go out and to do community health work if they're willing to do that. I do think it takes special people. So the challenge I find from Scale Up is that I think that the people who are willing to do the kind of work around sexual health, to go out into the communities, to do outreach. We hire people who are seasoned DIS workers to come and then work as outreach people for us. It's a special skill set that I think Dr. Boland mentioned earlier. We have to figure out a way to get those people out into the field. And that's probably from a workforce perspective, that's probably a bigger challenge. But I think manualizing the studies, afterwards having an opportunity to do that, particularly if it's successful, and then figuring out how to get the necessary workforce ready to go out and do the work probably is the other challenge. I guess I also wanted to comment about the impact of these statements. I think they're really important because then when I go back to then try to do something important, having this in a place that I can refer to as a scientist, I think is clinically and from a research perspective really important. I will say that people don't care about STDs until they have one. And so the reality becomes, but then at the same time, we've already talked about stigma and shame. So unlike other groups that can then take people into Congress, I think we've seen it. I think there's certain populations that people are very sensitive to. I think we have to think very carefully about how we allow our patients to have voice and what that looks like in Congress and what that looks like when people testify. I think it's a big sacrifice for a person to be on C-SPAN talking about their chlamydia, the average person who people would identify with. And I think that's something that after the recommendations come, people have to be very thoughtful about how it's packaged to the public and to the people making decisions about resources.
Dr. Trent, you mentioned the report of declining sexual behavior in adolescence. What does the panel feel about that trend and what's behind it?
I think people are engaged in different types of behavior now. Some of it electronic, some of it self-love, but I think the data suggests that people are actually still having physical contact with each other. So I think that there's a broad source of information about sex, but it may also suggest that when they do have sex, so physical contact, intercourse with another person of any kind, that sex itself may be unprotected, which is a challenge for us, even if it's with less frequency.
Do you think the report should engage topics like pornography and other things?
Full disclosure, I'm still a pediatrician. And I think that those topics are very complicated in pediatric settings. Our team actually has engaged those topics, particularly as it relates to populations who are very vulnerable and don't have information about sexual behavior or what it means to perform in the context of their sexual or gender identity. So I think that there are discussions we must have because I think there's data that young people are using it. It can create expectations around intimacy that may not reflect the reality. And so I think if we're not willing to have those discussions with young people, they will adapt them in ways that may ultimately be harmful for them.
Last question, Vincent Guillermo. I see they spelled it wrong here, but Guillermo Ramos.
Yeah, there are two L's. There's only one. Yes, so thanks. So really brief. I actually have two quick things. I promise I'll be brief. So the first is I wonder in particular, Dr. Tremp and anyone on the committee, about your thoughts regarding the important role of families, in particular parents, as it relates to adolescents and young adults, and sort of what would a report that addresses sort of familial influences, what would that look like? And I guess the other piece is that I was very struck, and I learned a lot from the overall presentation, but there was balance between very specific programs and what I'll call broader perspectives. And so from the point of view of having a report that is more likely to sort of be acted on, what guidance would you give all of us in terms of hitting those broader perspectives versus very specific steps that key stakeholders could take to address this issue?
Well, I'm clearly an advocate for you taking a broader approach. And because of all these issues are so interrelated, and this is such a good opportunity to really talk about the complexity, and some very broad kind of guidance would be really very helpful, with, again, illustrations of specific programs that have been shown to be effective.
For young people, parents are critical for many reasons. There are the people that talk with them about what their expectations are. There's good data that suggests that parents who have open conversation about relationships and intimacy with their young people, allow them to have discourse, actually delays initiation of sexual intercourse, which is a national health objective, to some degree as well. And align themselves sort of with the perspectives of their family. Not talking about it, though, often gets young people into trouble because they are not able to make decisions that are informed by any adult perspective at all. I think, though, that parents can have difficulty having those conversations, and so our efforts to support them, both from a knowledge perspective as well as a how-to perspective, to manage their own feelings. As somebody's full disclosure, I have my own adolescents. To allow them to manage their own feelings, to process that so that what comes out may not necessarily be how they feel at the moment, but they've had a chance to think about how they're going to talk to their young people. I do think in terms of, and so parents need skill building as well, support and skill building as well around sexual health issues. There's a national health curriculum. The first thing parents can do is they can talk about making sure that in their local communities that they can have a sexuality curriculum that is evidence-based and available to their young people. So parents are great advocates for sexual health, for STI prevention, parents sending young people off to college, having them be able to give those talks to their young person, putting a condom in their hand, taking their daughter to the gynecologist or to the adolescent medicine doctor, are all important aspects of helping them say to you, your sexual health is important to me, you're going to be away from me, let's make sure you have all your vaccinations and your physical, but let's also make sure you're ready to encounter this. I'm not saying you're going to have sex, but I want to give you everything I can to make sure that you're safe when you're out there. And then the final thing with a broader perspective, I think broader perspectives are extremely important to helping us conceptualize the direction that we're moving in. I do think people need examples. I think people who are out in the field trying to make a broad perspective work for them will benefit from some of the finer details as then they move forward to try to make decisions about how their agency, how their organization, how their foundation is then going to move to make the things that this committee presents to them come alive.
Besides the making recommendations for the kind of research that NIH does or the services that CDC does, I would hope that there are recommendations of what communities can do, what families can do, what schools can do, which religious institutions can do. This is going to take a village.
All right. On that note, thank you very much, all four of our speakers and panelists, and we'll have to move to the next session. So thanks so much.